All right, so we're gonna go over the ATI here and just go through the blueprint that our professor has given us. I was going over a couple of things on the slide, but it wasn't really helpful for me, and it's like she didn't put everything in there for us, so it's getting kind of irritating. So I rather just go into the lesson itself to get the information. If I can use this, oh my gosh, I can't use it. Hold on. Just listen to me then. My thing doesn't work on here. So, oh, there we go. The body. Okay. So here's one of the questions. It says, drag the laboratory test into the correct body system. So BUN would be a kidney function or a liver function? Kidney. Albumin, would that be a kidney or a liver function? Liver. ALT, would that be a kidney or a liver function? Liver. Creatinine, would that be a kidney or a liver function? Kidney. Bilirubin, would that be a kidney or a liver function? Liver. AST, would that be a kidney or a liver function? Liver function. Okay, so she did ask on here, I'm going to go over it again because I was going back and forth, but she did ask about fluid compartments, so this is going to be it. So the average person's weight consists of 1/2 to 2/3 water. For males, this, okay, oh, it doesn't say it here. Okay, fluid compartments, okay. So the body's water is located both within the cells and outside of the cells. The 2/3 of the total water are inside the cells. So there are 3 main fluid compartments, with the largest being the intracellular space, which holds 67% of the body's water. The other 2 compartments, collectively referred to the extracellular space, comprises the interstitial space, which contains 25% of the body's water, and the intravascular space, which holds the remaining 8% of the body's water. Okay. There are baroreceptors within the hypothalamic, the posterior pituitary gland, or whatever the case is. Right here it's showing you. To maintain the balance of fluids, the body utilizes various homeostatic mechanisms to retain water, such as the thirst response. Okay. Risk factors for fluid electrolyte imbalances. I'm looking to see if we can. Okay. So this is the electrolytes that we're studying. Potassium would be from 3.5 to 5. Sodium would be 135, but really it says 136 to, I'm going to say 135 to 145. Calcium, I said it was like 8.5 to 10.5, but I think this says like 9 to 10.5. Magnesium, I'm remembering it as 1.5 to 2.5. Yeah. Okay. So potassium is the body's largest intracellular electrolyte. Its function is to support the transmission of electrical impulses of the body's nerves and muscles. Potassium also plays a major role in the conduction of nerve cells within the heart. The body maintains a narrow range. Okay. Hypokalemia can occur from several causes: medications, certain cardiac conditions, gastrointestinal loss, metabolic alkalosis, decrease oral intake of potassium, excessive alcohol use, chronic kidney disease, diabetic ketoacidosis, so DKA, excessive sweating, excessive sweating, hypokalemia. Okay, folic acid deficiency. Okay, the most common cause of hypokalemia is the loss of potassium from the kidneys or gastrointestinal tract. Potassium wasting diuretics like loop, thiazide, and osmotic are the medications that most commonly result in hypokalemia through urine loss. So loop, diuretic, thiazide, and osmotic. Other medications that can lead to decrease in potassium level include amphotericin B, high doses of penicillin, and theophylline. So decreases of potassium from gastrointestinal loss may result from prolonged diarrhea, vomiting, as well as from chronic laxative use, bowel diversion, or gastric suctioning. So that says like mild hypokalemia from 3 to 3.5 may not present with any signs. Mild hypokalemia, you can see muscle weakness, cardiac arrhythmias. Okay, so common manifestations that can be seen with hypokalemia of less than 3. Okay, this is not mild, right? Yeah. Okay, so hypokalemia, you can see muscle weakness, cardiac arrhythmias, constipation, and fatigue. With severe life-threatening hypokalemia, defined as a potassium level less than 2.5, respiratory paralysis and failure can occur. Other manifestations of severe hypokalemia may include paralytic ileus, obstruction of the intestine, hypotension, tetany, rhabdomyolysis, muscle tissue breakdown, and life-threatening cardiac arrhythmias. Repeated episodes of hypokalemia can affect renal function. Okay. You can, for the interventions to this would be like to treat hypokalemia, you can give them a supplementation to restore levels of it. There's supplements in forms of oral medications or intravenous infusion. Oral supplements can cause gastrointestinal distress, so they should be administered with or following a meal. Okay, so drag the manifestations in the column to match with the correct condition in the right column. So mild hypokalemia and severe hypokalemia. Paralytic ileus, severe. Hypotension, I think mild. Nope, hypotension is severe. Respiratory paralysis, severe. Muscle weakness would be mild. Constipation would be mild. Rhabdomyolysis would be severe. Cardiac arrhythmia would be severe. Cardiac arrhythmias is mild. Fatigue is mild. And tetany is mild. Damn. Oh, tetany is severe. What the hell? Okay, so mild hypokalemia is muscle weakness, constipation, cardiac arrhythmias, and fatigue. Severe hypokalemia is paralytic ileus, hypotension, respiratory paralysis, rhabdomyolysis, and tetany. Rhabdomyolysis, tetany, hypotension for severe. And then, what is it called? Mild hypokalemia is 3 to 3.5, and then lower than 3, I guess medium. Common manifestations that can be seen with hypokalemia of less than 3. And then the severe would be 2.5 milliequivalents of hypopotassium. Okay. So a nurse is caring for a client who is admitted to the medical unit for hypokalemia. Which of the following conditions can cause hypokalemia? We know medications can, chronic kidney disease, DKA, folic acid deficiency. All right. Also, potassium that are high in food. Foods high in potassium, the highest would be, guess what? A baked potato, 941, one medium potato. And then prune juice, 1 cup is 707. Carrot juice at 689. White beans at 595. Plain yogurt, 579 a cup. Sweet potatoes, 542. Salmon is, so, yeah. Isn't that funny? Okay. Let's talk about hyperkalemia. That's going to be higher than 5. Critical values occur at levels greater than 6.1. So critical values occur at levels greater than 6.1 and greater than 8.0 for newborns. Whoa. The body maintains the potassium level within a narrow range, and deviation can lead to significant neurological, respiratory, and cardiac consequences. So hyperkalemia can occur from several causes: renal failure, dehydration, diabetes mellitus, medications, trauma, excess intake of potassium, burns, transfusions of packed red blood cells. Oh, transfusions of packed red blood cells can give you hyperkalemia, metabolic acidosis, and sepsis. So the most common cause of hyperkalemia is renal failure. Potassium-sparing diuretics like so the most common cause of hyperkalemia is renal failure. Potassium-sparing diuretics, non-steroidal anti-inflammatory medications or NSAIDs, and angiotensin-converting enzymes, ACE inhibitors, are the medications that most commonly result in hyperkalemia. Mild hyperkalemia is usually asymptomatic. However, high potassium levels may cause life-threatening cardiac arrhythmias, muscle weakness, or paralysis. With severe life-threatening hyperkalemia defined as a potassium level greater than 7 milliequivalents, this could be seen as paralysis and heart failure are possible. If severe hyperkalemia is untreated, death can occur. Routine blood tests such as the basic metabolic panel or the comprehensive metabolic panel are used to measure potassium levels, and the provider may prescribe an ECG to determine if the level of potassium is affecting the rhythm of the heart. If the elevated potassium level is due to renal failure, hemodialysis may be required. Other treatment options for hyperkalemia include medications such as calcium gluconate and diuretics. Calcium gluconate or calcium chloride can be utilized to decrease the effects of excess potassium levels on the heart. Loop and thiazide diuretics cause the body to excrete excessive potassium through urination. The provider may also prescribe a resin medication such as sodium polyestrine to help decrease potassium levels. Resins bind to the potassium in the body and are then excreted through the stool. Other treatments include the administration of insulin, which causes potassium to enter the cells, which lowers the serum potassium level. Clients receive insulin to treat hyperkalemia should have blood glucose monitoring because of the increased risk of hypoglycemia, which defined as blood glucose level less than the expected reference range of 74 to 106 milligrams per deciliter. So yeah, the provider may instruct the client with hyperkalemia to lower potassium levels by decreasing dietary consumption. A nurse is reviewing the medical history of a client who is experiencing hyperkalemia. Which of the following findings put the client at a higher risk for hyperkalemia? The use of potassium supplements, Kidney failure. Yeah, that's the ones. Okay, let's talk about sodium hypernatremia. Okay, sodium is the body's most common extracellular electrolyte. It supports proper neurological and neuromuscular function. So neurological and neuromuscular function. It regulates the body's fluid balance and helps maintain blood pressure. So fluid balance and blood pressure. Sodium is ingested into the body through food and drink and is excreted primarily through the urine and sweat. The RDA for sodium is less than 2,300 milligrams per day, or approximately 1 teaspoon. 1 teaspoon, crazy. Yeah, the expected reference range of sodium is 136 to 145. Hyponatremia occurs when levels of sodium fall below 136, and critical values occur at less than 120 milliequivalents. There are multiple factors that can place a client at risk for developing hyponatremia, such as medications, chronic or severe vomiting or diarrhea, drinking excess amounts of water, excess alcohol intake, heart, kidney, and liver problems, and severe burns. Excess water in the body rather than a lack of sodium is the most common cause of hyponatremia, as the presence of too much water dilutes the sodium level. Thiazide diuretics are the medications that most commonly result in hyponatremia. Is that? As they can cause the loss of sodium through urine loss. How come? Okay, can I like, oh my gosh. I try to do something and, okay, whatever. Jeez, so picky. I don't even know where we're at anymore. Jeez. Were we just at 1? No, we were here. I saw this. Oh, now you want to highlight. Jeez. Where are we at? Sodium, right? Okay, excess water in the body rather than a lack of sodium is the most common cause of hyponatremia, as the presence of too much water dilutes the sodium level. Thiazide diuretics are the medications that most commonly result in hyponatremia, as they cause loss of sodium through urinary loss. Gastrointestinal losses can occur with prolonged diarrhea or vomiting. Diseases such as heart failure and cirrhosis lead to increased retention of fluid in the body, which dilutes sodium, when certain kidney conditions can lead to excess excretion of sodium. While certain kidney conditions can lead to excess secretion of sodium. Okay. Diseases such as heart failure and cirrhosis lead to increased retention of fluid in the body, which dilutes the sodium. Okay. Manifestations such as nausea and a feeling of general unwellness can occur with even mild hyponatremia. The neurological manifestations are related to fluid shifts in the brain, which leads to cerebral edema. Moderate hyponatremia often manifests first with lethargy and confusion. Other neurological changes may include headache, restlessness, and irritability. As hyponatremia becomes more severe, muscle twitching further decreases in level of consciousness, seizures, and a coma can occur. If hyponatremia is not reversed, a client can become unarousable and death can occur. Okay. Okay, so if the cause of low sodium levels is related to excess water intake or an alteration in the fluid balance, the treatment may include fluid restriction to correct the dilution effect. Okay, if the cause is related to sodium and fluid losses, IV fluids are administered to restore sodium and water balance. Okay, so the interventions would be drinking water. This is for hyponatremia, drinking water in moderation. Check urine for pale yellow color to indicate adequate hydration. And discuss with the provider the need to consume sports drinks with electrolytes when participating in demanding physical activities. Use thirst as an indicator as to whether or not to drink water is necessary. Older adults are prone to hyponatremia due to the physiological aspects of aging, the increased number of comorbidities in this population, and the greater use of medications. So hypernatremia occurs when it's above 145. Hypernatremia is most commonly seen when the body water loss is greater than the sodium loss. However, it can be a result of too much water or a combination of two. So hypernatremia can occur from the following causes: loss of body water, medications, gastroenteritis, vomiting, prolonged suction like NG suction, burns, excessive sweating, chronic kidney disease, diabetes, and impaired thirst response. Loss of body water is the most common cause of hypernatremia. As water is removed from the body, dehydration occurs, which stimulates the thirst response. Dehydration is diagnosed most often in infants and older adults due to their inability to communicate the thirst response or diminished thirst response. High sodium levels result in the manifestations like those seen in hyponatremia, which is like confusion, lethargy, and irritability. As hypernatremia becomes more severe, you have muscle twitching and further changes in level of consciousness, with seizures and coma can occur. If not corrected, hypernatremia will eventually lead to death. Hypernatremia, so a BMP or a CMP, so we can diagnose that. Treatment for hypernatremia include identifying the cause and initiating intravenous fluid replacement containing water and a small amount of sodium. And decrease the sodium levels slowly to prevent cerebral edema. Oh, so the foods highest in sodium: roasted ham. 3 ounces of roasted ham has 1,117 milligrams. Shrimp has high sodium. Frozen non-breaded, 3 ounces, 800 milligrams. Oh my God. Frozen pizza at $7.65 for 1 large slice. Canned soup is 700 milligrams. Vegetable juice, 405. Cottage cheese at 350. Oh my gosh. Okay, so nurses caring for a client who has hyponatremia, which of the following findings or intravenous intervention should the nurse suspect? Hyponatremia, so sodium levels of 127. Client report headache and fatigue. That's it, I think. This? Okay, prescription of a urine sodium test. Okay. So let's talk about calcium now. So calcium is the most abundant mineral in the body and has multiple functions. While calcium is found in the blood and cells, 99% of it is stored in the bones and teeth. Calcium plays a role in the following activities: mineralization of bone, muscle contraction, nerve transmission, clotting of blood, hormone secretion, and normal functioning of the heart. Let's go through that again. Calcium plays a role in the following activities. So mineralization of the bone, muscle contraction, nerve transmission, clotting of blood, hormone secretion, and normal function of the heart. Absorption of calcium by the intestines depends on an adequate supply of vitamin D. Okay, so the RDA for vitamin D is 600 international units for adults and 800 international units for older adults. But you need to like do some like weight bearing activities to do that anyway. Strengthen the bones and absorb it, right? I think anyway. So excretion of calcium occurs through the kidneys and is controlled by the action of the parathyroid hormone. So yeah. Okay, so the expected reference range for serum calcium for an adult is 9 to 10.5. However, much of the calcium in the body is bound to protein, so a more accurate analysis is provided by assessing an ionized calcium level. This represents the active or unbound amount of calcium in the blood. The expected reference range for ionized calcium for an adult is 4.5 to 5.6. Okay, let's talk about hypocalcemia. So hypocalcemia occurs when serum calcium levels are below 9 and ionized levels are less than 4.5. Critical values occur at less than 6. So 6 for hypocalcemia. Let's talk about... Oh my gosh, my eye is itchy. Okay, so hypokalemia can occur from several causes. Medications that decrease the body's absorption of calcium, inadequate amounts of vitamin D, hormonal changes like menopause, hypoparathyroidism, renal disease, multiple blood transfusions for hypocalcemia. Okay, electrolyte imbalances of magnesium or phosphate. Sepsis, low albumin levels. So medications that can lead to hypocalcemia include stimulants like laxatives, which decrease the absorption of calcium. Long-term use of glucocorticoids, which can deplete calcium stores by increasing the client's risk of developing osteoporosis, and loop diuretics, which can lead to excess calcium excretion by the kidneys. Medications used to decrease the body's gastric acid, for example, like proton pump inhibitors, PPIs, and histamine 2 blockers can lead to hypocalcemia by decreasing the breakdown of fat, a factor that is important for calcium absorption. Another potential cause of hypocalcemia is a lack of circulating parathyroid hormone. The parathyroid gland, which are located in the neck behind the thyroid gland, are responsible for the secretion of the parathyroid hormone, or PTH. The function of PTH is to maintain the proper amount of calcium in the body. Among the various causes of decreased PTH in the body, the most common are thyroid or neck surgery. Decreased PTH may lead to the need for lifetime supplementation of calcium. Hormonal changes that occur in menopause place older adults at risk for hypocalcemia. Decreased estrogen production can inhibit the absorption of calcium, as well as hasten the reabsorption of loss of bone. Over time, the body takes calcium from bone, where it stores, as to maintain sufficient calcium levels in the blood. Hold on. Hypocalcemia can lead to osteopenia, also known as low bone mass, and increase the risk of bone fractures and osteoporosis. Hypocalcemia affects multiple body systems, including the respiratory, cardiac, neurological, sensory, neuromuscular, and integumentary system. Acute cases can be associated with cardiovascular manifestations such as chest pain, dysrhythmias, heart failure, and syncope or faint. Syncope. Neuromuscular manifestations may be more noticeable to the client and includes numbness, tingling of the fingers and toes around the mouth, muscle cramping, spasms, particularly in the back and lower extremities. Neurological manifestations may include confusion, depression, psychosis, dementia, lethargy, seizures, and personality changes. Respiratory changes may include wheezing, spasm of the larynx, airway, dysphagia, and changes to the voice. Oh my God. Integumentary changes include coarseness of the hair, hair loss, brittle nails, dry skin, and itching. I did not know that. It says neonates and infants are at greater risk for hypocalcemia if they are born to mothers who have diabetes and preeclampsia or hyperparathyroidism. Okay, so two distinct findings can be elicited if hypocalcemia is suspected. The Chbosky sign and the Trousseau sign. Hypocalcemia may resolve on its own or treatment may be required. If it's severe, they may include calcium and vitamin D supplements. Yeah. It looks like cheese and milk. Okay, hypercalcemia, higher than 10.5. Critical value is over 13. Elevated serum calcium levels can lead to the development of kidney stones, weaken bones, and affect the function of the heart and brain. Hypercalcemia is most commonly caused by the following factors: cancer, hyperparathyroidism, vitamin D toxicity, medications, and renal failure. The most common causes of hypercalcemia are hyperparathyroidism and cancer. Both of these conditions result in excessive calcium being drawn from the bones and into the bloodstream. In hyperparathyroidism, the parathyroid glands secrete excessive amounts of PTH. As cancer progresses and bones are invaded, bone reabsorption occurs. As a result of this process, the cancer tumor releases a hormone similar to PTH, which leads to increasing levels of calcium. Hypercalcemia can be caused by medications such as calcium, vitamin D, and A supplements, thiazide, diuretics, and lithium carbonate. In addition, prolonged bed rest can result in elevated serum calcium levels. This condition occurs with a period of days or weeks, but is quickly reversed when the client begins to engage in weight-bearing activities and becomes more active in general. Mild hypercalcemia rarely produce symptoms. Gastrointestinal manifestations such as constipation and abdominal pain, nausea and vomiting, and anorexia are usually the first indications that a client will notice. As calcium levels increase, confusion and behavioral changes can occur, along with thirst, polyuria, bone pain, and muscle weakness. Okay. Abdominal groans, painful bones, kidney stones, and psychiatric moans and fatigue overtones. So, okay, so magnesium is the body's second most common intracellular electrolyte. As with calcium, much of the body's stores of magnesium, 50 to 60%, is located in bones. Magnesium's role in the body is to assist in the regulation of nerve and muscle function, maintain blood pressure and serum glucose levels,
I need to grab something.
support bone and teeth health, and synthesize protein. The intake of magnesium occurs through the digestion of whole foods. Many foods produce a fortified with magnesium.
Have you seen that? Oh, thank you.
So, close the door.
Wow.
Magnesium has an expected reference range from 1.5 to 2.5. When levels of magnesium fall below 1.3, critical values occur at less than 0.5 or greater. Okay, so hypomagnesemia may be caused by several different factors. Medications, decreased absorption by the intestines like Crohn's disease and celiac disease, increased excretion by the GI tract, diarrhea and pancreatitis, excessive alcohol use, this is hypomagnesemia, diabetes mellitus type 2, undernutrition, severe burns, electrolyte imbalances such as like hypokalemia, and hypocalcemia. Medications that can lead to magnesium loss would be loop or thiazide diuretics, certain antibiotics, and PPIs. Okay, clinical signs of hypomagnesemia usually do not occur until the levels drop below 1.2. Okay. Okay. Neuromuscular changes such as muscle cramps and spasticity, numbness and tingling and seizures, tetany, and personality changes. So when it's okay, so it has to drop below 1.2, but if it goes further, that's when you have that because magnesemia or magnesium helps like relax the body, like hot. Like I said earlier with my other video, like they use like magnesium, a high amount of magnesium, to help stop like labor to occur with like mothers that go into term labor. So the opposite of that, so hypomagnesemia, you're gonna have like all these, it's like they said, like it's not gonna be, it's gonna be the opposite of chill, right? You have cramps, spasms, cardiac dysrhythmias, muscle cramps, spasticity, numbness and tingling, and seizures, tetany. Hypokalemia and hypocalcemia may also be present if magnesium levels are severely low. Parenteral magnesium replacement is reserved for clients who have severe manifestations or cannot tolerate oral magnesium. Cooked spinach has like a really high amount of magnesium at 156. Pumpkin seeds, black beans, soybeans, cashews, dark chocolate, avocados, tofu, banana. Hypermagnesemia is a magnesium level above 1.3. While hypomagnesemia is relatively common, excessive magnesium in the blood is a rare occurrence. This can be from kidney disease, acute and chronic, excessive intake, medications, trauma, acidotic states, and hypothyroidism. The most common cause of hypermagnesemia is acute or chronic kidney disease. Laxatives and antacids containing magnesium may also cause hypermagnesemia if intake is excessive. When magnesium levels exceed 7 milligrams, moderate neurological manifestations may occur, such as increased confusion, sleepiness, blurred vision, and headache. Decreased reflexes, bladder paralysis, flushing, and constipation may also be present. Severe reactions, so greater than 12. Muscle flaccid paralysis, decreased respiratory rate, hypotension, and bradycardia. If the imbalance is not corrected, seizure, coma, cardiac arrest, and death. Okay, so I wanted to go over, hypovolemia. This is fluid overload. The body has too much water. Fluid losses, dehydration. You can get that from diarrhea, vomiting, sweating too much, urinating too much due to medications, illnesses such as diabetes, ketoacidosis, fever, and insufficient water supply or an impaired thirst response. Hypovolemia can occur from the following causes: blood loss, gastrointestinal losses, severe burns, third spacing, excessive sweating, fever, medication trauma. Third spacing, in which fluids become sequesters. I don't even know what that says. Sequestered in other body cavities as an outcome of disorders such as cirrhosis and pancreatitis. Hypovolemia. Let's see. Hypervolemia and hypovolemia. Hypovolemia can be caused by third spacing, severe burns, gastrointestinal losses. Early manifestation of hypovolemia include thirst, dryness of mucous membranes, decreased skin turgor, decreased urine output. If the circulating volume loss becomes greater than 20% of the total volume, hypovolemic shock can occur. If not reversed, the lack of perfusion to the vital organs can lead to multiple organ failure. A BUN greater than 20. Hypervolemia is a fluid condition in which the body has too much water and sodium in the extracellular space. Okay, so fluid body has too much water and the sodium in the extracellular space, particularly the interstitial compartment. This can result from heart failure, kidney failure, nephrotic syndrome, cirrhosis, or end-stage liver disease. Okay, so a client who has heart failure can experience hypervolemia because the heart is no longer able to effectively circulate the blood. A condition that also impacts the ability of the kidneys to excrete fluid, leading to a fluid imbalance. Cirrhosis and inflammation of the liver associated with fibrosis of the tissues can cause fluid retention and edema as fluid becomes sequestered in the abdomen. Pregnancy alters the balance of a woman's hormones, resulting in hypervolemia. Medications used to treat hypertension, such as vasodilators, calcium channel blockers, as well as galitazones used to treat type 2 diabetes, can cause sodium and water retention. Okay. I was hoping I could get through this. Hold on. Rehydration. Age-related I'm checking to see if there's anything. We know the colloidal solutions. We should look at the blood volume. Let's just go through this. Okay, 0.5 is hypotonic. This almost sounds like isotonic. No. Is it hypotonic? Oh my gosh, it's hypertonic. This looks like hypertonic. Yep. This is isotonic. This looks like hypertonic. This looks like hypertonic. Is it? D5W. Would that be isotonic? No. It's isotonic? Okay. Is this isotonic? No. Okay. So isotonic would be lactated ringers or D5W. Hypotonic would be 0.45% NaCl. Hypertonic would be like D10W, D5NS, D5LR, D5 1/2, what is it called, natural saline or something like that. Where's the blood transfusions? Blood product transfusions. Can I have this play? My freaking throat's sore.
Blood product transfusion. If fluid loss in the body is due to hemorrhage from trauma, it may be necessary to replace the loss with blood products. Blood is the circulating fluid within our bodies that carries oxygen.
Why is it doing that?
And nourishment to our cells and
oh my god, it sounds crisp. Okay, so if fluid loss in the body is due to hemorrhaging from trauma, it may be necessary to replace the loss of blood with products. Okay. What do we need to know about blood transfusions? There's 3 questions. Is there a test here that we can take? Maybe they're talking about like blood types. Okay, so transfusion reactions can be acute, occurring within with 24 hours of the transfusion, often while the blood is transfusing. So manifestations may vary depending on the cause, but include the following: fever, chills, alteration of blood pressure, elevated or decrease, respiratory difficulty, wheezing, coughing, dyspnea, pain in the chest, abdomen, low back or flank pain, nausea or vomiting, skin manifestations including pruritus, urticaria, flushing, edema, localized and rash, jaundice. Urinary changes include oliguria, anuria, and hematuria. The most common acute transfusion reaction include acute hemolytic reactions, which occur when the blood transfusion is not compatible with the blood of the client. Febrile non-hemolytic transfusion reactions, allergic reactions, which can range from mild to anaphylactic transfusion-related acute lung injury, which results in edema of the lung tissues and airways, and transfusion-associated circulatory overload, TACO, which is often the result of too rapid administration of blood products. Delayed reactions can occur as early as 2 days to as long as several weeks after a transfusion and are the result of an incompatibility between the donor's and the client's RBC or the T lymphocyte antigens. Let's see. Okay, so match the blood type to the blood type to which can be donated. So A negative, I think, can give to like I think it can give to this. Yeah. So A negative can give to, I think it says match blood types, which can donate. So A negative can give to A negative to A positive to AB negative and AB positive. So AB positive, I think they can only give to AB positive. Yeah. B positive can probably just give to. I think it can probably just give to B positive and AB positive. Yeah. B negative probably can give to B negative. I think it's this one. To B negative, B positive, AB negative, and AB positive. So A positive probably can just give to A positive, right? Oh, and AB positive. I think that's right, yeah. AB negative can give to AB negative and AB positive. O negative can give to everyone. And I am an O positive, so I can only give to A positive, B positive, AB positive, and O. Hey, at least I have 4 that I can give to. Okay. So a nurse is discussing with a newly licensed nurse anaphylaxis that can occur during a blood transfusion. Which of the following manifestations should the nurse include in the discussion? So a nurse is discussing with a newly licensed nurse anaphylaxis that can occur during a blood transfusion. Which of the following manifestations should the nurse include? We're talking about manifestations of anaphylaxis, right? Anaphylaxis is like closing up. Wouldn't it be bronchospasms? Yeah, that's the only one. The nurse should discuss that bronchospasms, hypotension, tachycardia, urticaria, nausea, vomiting, anxiety, and shock are manifestations that can occur while the client is receiving blood. Is there any other test? I don't think so. Let me see if there's anything cool. Okay, so a nurse should stay with a client for the first 15 minutes of a blood or blood product transfusion. Let me see if there's anything highlighted. Anything else highlighted here? Whole blood. Combination of red cells, white cells, and platelets in blood plasma. Red blood cells, also known as erythrocyte, a component of blood that contains hemoglobins that are responsible for oxygen and carbon dioxide transport. Hematocrit, It measures the RBCs in total blood volume. Oh, so the labs. Maybe they want us to know the labs. I don't know. So red blood cell count. I don't know about that. So hemoglobin, we're looking at like 14 to 18. Hematocrit, we're looking at 42 to 52%. White blood count, 5 to 10,000. And platelet count is like buying a house, 150,000 to 400,000. The down payment would be the white blood cell count, which is 5,000 to 10,000. 42 to 52% of the time is how much hemoglobin, 14 to 18. It's a percentage. Hematocrit is a percentage. Indications for the transfusion of RBCs include surgery, anemia, trauma, blood loss, cancer, and blood disorders such as sickle cell disease. RBCs can be transfused to restore blood levels without sustainably increasing the client's overall blood volume. As the liquid portion of whole blood, the plasma is removed from the transfused material. A transfused unit of packed red blood cells typically raises the hemoglobin levels by 1 gram per deciliter and the hematocrit by 3%. Transfusions of packed red blood cells are usually administered when the hemoglobin levels reach 7 to 8 grams. What's 7 to 8? Hemoglobin? I think it's 14 to 18, yeah. 14 to 18. White blood cells, also known as leukocytes. Plasma, the liquid portion of blood, constitutes about 55% of whole blood. Consists mostly of water. In addition to transporting the cells, plasma helps maintain a blood pressure and volume. Contains numerous clotting factors and works with platelets to minimize bleeding. Plasma contains several types of proteins, with albumin being the largest molecule. Plasma transfusions are most often given to clients who have experienced trauma, who have a major burn, or who are in shock. Experienced trauma, who have a major burn, or who are in shock. Autologous blood transfusion is performed with the client's own blood that was previously donated. Indications for autologous donation includes a scheduled elective surgery that has increased risk for large blood loss, such as a total hip arthroplasty, and anticipation of a high likelihood for a blood transfusion. A client who has a rare blood type with a limited supply of donors, who has a cultural or religious objection of receiving blood products from others, may choose autologous donation. We already did blood types. The universal donor blood type is O negative. The universal recipient blood type is AB positive. Prior to receiving a blood transfusion, a client must be typed and cross-matched to ensure that the donated blood is compatible. The laboratory test involves drawing a blood specimen from the client and determining the ABO type of blood and Rh factor. Prior to administering transfusions, the client must sign a consent form to receive a blood product. The client should have an 18 to 20 gauge IV access that is patent and ready in place before a nurse receives the blood product. 2 nurses must check to compare the blood unit label. Transfusion should be completed within 4 hours of leaving controlled temperature storage. Okay, so at bedside, 2 nurses must check and compare the blood unit label and the client's identification information and ensure compatibility of the unit with the client's blood type. Administering blood and blood products should be done with caution and using aseptic technique. Blood should be transfused by an RN. A nurse should remain with the client during the first 15 minutes of the transfusion, as most transfusion reactions occur within that time frame. Vital signs should be routinely checked 15 minutes after starting the transfusion. It is critical to recognize when a transfusion reaction is occurring, as prompt clinical management can prevent serious injury to the client. If a reaction is suspected, the priority is to stop the transfusion while keeping IV access open using an infusion of 0.9 sodium chloride. It is necessary to replace the administration set because a significant amount of blood may still be present within the tubing. The blood unit label and the client identification should be compared again to verify the blood product was administered with the correct client. The blood unit should be returned to the blood bank with a sample of blood from the client for investigating of the reaction. The nurse should remain with the client, continue to monitor the client's status, support respirations if needed, and notify the provider. Transfusion associated circulatory overload. It happens when a large volume is infused for a short period of time. You'll have tachycardia, jugular venous distension, increased blood pressure, dyspnea, orthopnea, and cyanosis. Stop the transfusion. Place the client in high Fowler's position. Notify the provider and administer oxygen. Acute hemolytic reaction occurs when a client receives blood components that are not compatible with their own. We have fever, chills, tachycardia, hypotension, flank pain. Stop the transfusion, call for rapid response, change the administration set and infuse 0.9 sodium chloride and treat for shock. Non-hemolytic febrile reaction, so antibodies attack the client's leukocytes or platelets. We have fever, chills, headache, nausea, and vomiting. Stop the transfusion, notify the provider, change the administration set and infuse 0.9 chloride. Monitor vital signs. If prescribed, restart transfusion slowly. Allergic reaction, mild. Occurs when the client is allergic to something in the infusion. Pruritus, urticaria, wheezing, facial flushing. Stop the infusion, notify the provider, infuse 0.9 chloride to keep the vein open, monitor vital signs if prescribed, and start. Anaphylaxis occurs when the client has antibodies to components of the donor's blood. Hypotension, tachycardia, bronchial spasm, urticaria, anxiety, nausea, vomiting, and shock. Transfusion-related acute lung injury, or TRALI. This occurs when the client has antibodies to the WBCs in the donor blood. You'll have pulmonary edema, delayed reactions. Okay, that is it for now. I gotta go. I'm tired. That was only like the first fucking... I should have been doing this for each chapter, but... So she has 3 questions on blood transfusions. We went over... So interventions for hypernatremia and hypokalemia. Signs and symptoms of hypervolemia. Clients most likely to have high potassium, low sodium, low calcium, and low magnesium. electrolyte functions and fluid compartments. She has some stuff about like medications on pain, like non-opioid medication, pain scales, that kind of stuff. I have a long day tomorrow. I'm just gonna give myself 10 minutes and see if I want to take the exam. Okay, bye.